The following is a review of spinal cord blood flow. The spinal cord circulation consists of 2 posterior spinal arteries, 1 anterior spinal artery, and 6 to 8 radicular arteries. Regarding the posterior spinal artery flow, it goes from the aorta to the subclavian artery to the vertebral artery to the posterior spinal artery, and also from the aorta to the segmental artery to the posterior radicular arteries to the posterior spinal arteries. And it perfuses the posterior one-third of the spinal cord, which is illustrated in green on the picture to the right. Regarding the anterior spinal artery, there's only one, and blood flow is from the aorta to the subclavian artery to the vertebral artery to the anterior spinal artery, and from the aorta to the segmental artery to the anterior radicular artery to the anterior spinal artery, and the anterior spinal artery perfuses the anterior two-thirds of the spinal cord, illustrated in yellow on the picture to the right. Regarding the artery of Adamkiewicz, it is the most important radicular artery. So the artery of Adamkiewicz is a radicular artery, and it perfuses the anterior spinal cord in the thoracolumbar region. It most commonly originates on the left side between T11 and T12. In 75% of the population, it originates between T8 to T12, and in another 10%, it arises at L1 to L2. It is critical to understand the spinal cord is perfused at each segment, but not necessarily along its entire length. Some regions of the cord only have a single blood supply. These are called watershed areas, and they're particularly vulnerable to ischemia. For example, the thoracolumbar region of the anterior spinal cord is highly dependent on the radicular arteries. Interruption of radicular flow can cause ischemia or infarction to the corresponding spinal cord segments. Next, we'll talk about anterior spinal artery syndrome. An aortic cross-clamped above the artery of Adamkiewicz can cause ischemia to the lower portion of the anterior spinal cord. This can result in anterior spinal artery syndrome, otherwise known as Beck syndrome. Classic signs and symptoms include flaccid paralysis of the lower extremities, bowel and bladder dysfunction, loss of temperature and pain sensation, and preserved touch and proprioception. We tend to generalize that the anterior spinal cord contains motor neurons and the posterior spinal cord contains sensory neurons. And while this is enough to get you by in most situations, we're going to dig deeper to help you understand the presentation of anterior spinal artery syndrome. So the presentation of flaccid paralysis of the lower extremity is because the corticospinal tract is perfused by the anterior blood supply. The presentation of bowel and bladder dysfunction is because the autonomic motor fibers are also perfused by the anterior blood supply. And the patient loses pain and temperature sensation because the spinal thalamic tract is perfused by the anterior blood supply. And lastly, the dorsal column is actually perfused by the posterior blood supply, and this explains why touch and proprioception are spared in this patient. Next, we're going to talk about the anatomy of the spinal cord. The spinal cord links the peripheral nerves to the brain. Sensory neurons from the periphery enter the spinal cord via the dorsal nerve root, while motor and autonomic neurons exit via the ventral nerve root. The picture below illustrates the various anatomical aspects of the spinal cord and ventral and dorsal roots. On the posterior side, you have the dorsal median sulcus, which is a type of cleft that's in the middle of the posterior aspect of the cord. And then you have the ventral median fissure, which is a similar cleft on the anterior aspect of the cord. The yellow represents white matter, which is axons and supporting cells, and the horns are illustrated in gray because these are actually the gray matter, which consists of cell bodies. In the middle, there's a circle that represents the central canal that has CSF in it, and then you have the ventral and dorsal roots. So the anterior root is the ventral nerve root, which contains motor and autonomic, and then the dorsal nerve root contains sensory. So moving on, a ganglion is a collection of cell bodies that reside outside of the central nervous system. Regarding gray matter, the gray matter contains neuronal cell bodies. This is the processing center for afferent signals that arrive from the periphery. Notice the H shape. This is important for you to determine the orientation. If this was a hotspot that was upside down, would you be able to determine the correct orientation of the spinal cord, specifically the gray matter spinal cord? Regarding laminae, The gray matter is subdivided into 9 laminae. Laminae 1 through 6 reside in the dorsal gray matter, and these are sensory. Lamina 7 through 9 reside in the ventral gray matter, and these are motor. Regarding regional differences, the gray matter is larger in 2 specific regions in the spinal cord. The region of the cervical enlargement, which is C5 to C7, and this houses the cell bodies for the neurons that supply upper extremities. The region of lumbar enlargement, which is L3 to S2, houses the cell bodies for neurons that supply the lower extremities. Regarding white matter, this contains the axons of the ascending and descending tracts. It is divided into the dorsal, lateral, and ventral columns. A tract is a group of fibers inside the white matter in the CNS that relay information up or down the spinal cord or to and from the brain. The following picture illustrates the various sensory and motor tracts. So on the left, illustrated in an emerald green or forest green, is the dorsal column, which consists of the cuneatus and gracilis. So the most lateral aspect is the cuneatus, and then medial to that is the gracilis. And these are involved in fine touch and proprioception. And a brownish color is the tract of Lesueur, which is just lateral to the dorsal column cuneatus. And the tract of Lesueur is part of the spinothalamic tract. And then completely lateral, so on the side in a bluish color, you're going to see the lateral spinothalamic tract, which is responsible for pain and temperature. And then more anterior to that, you have the ventral spinothalamic tract. So you have 2 spinothalamic tracts, the lateral spinothalamic tract for pain and temperature, and the ventral spinothalamic tract, which is involved in crude touch and pressure. And then over on the right are the motor tracts, so sort of the lateral and posterior aspect of the spinal cord. And the white matter is the lateral corticospinal tract, which is the limb motor. And then more anterior to that, you have the ventral corticospinal tract, and this is involved in posture. So this is your posture motor. And they are called the corticospinal tracts because they originate from the cortex and travel down the spinal cord, as opposed to the sensory tracts are called spinothalamic tracts because they originate in the spine or the spinal cord, and they travel up to the thalamus, which is of course then sent to be interpreted by the cortex. The name of the tract will often give you a clue about its function. Many times the first half of the name indicates where the tract begins and the second half of the name indicates where the tract ends. So we kind of already just reviewed that. The corticospinal tract travels from the cortex to the spine. This is clearly a motor pathway, and the spinothalamic tract travels from the spine to the thalamus, and this is clearly a sensory pathway. Some of the pathways aren't quite this easy, but thinking about them in this way should help get you started. You should know the following questions about each pathway. What is the anatomical organization of each tract? What types of sensation are transmitted, meaning pain, touch, proprioception, etc.? How fast does each pathway relay information? Where does the pathway cross to the contralateral side of the body? And what happens when the pathway is injured? Next, we're going to review sensory pathways of the DCML, the dorsal column medial lemniscal system. The DCML transmits mechanoreceptive sensations such as fine touch, proprioception, and vibration, and pressure. Regarding the pressure, it has a very fine degree of intensity. The DCML is capable of 2-point discrimination, meaning it has a high degree of localization to the stimulus. And the DCML consists of large, myelinated, rapidly conducting fibers. The DCML transmits sensory information faster than the anterolateral system. Regarding peripheral receptors, the following table lists the mechanical receptor type and functions specific to that receptor. First are Meissner's corpuscles, and these involve 2-point discriminative touch and vibration. There's also Merkel's disc, which is continuous touch, Ruffini's endings, which is proprioception and prolonged touch and pressure, And lastly, there's Pacinian corpuscles, which are involved in sensing vibration. The following diagram illustrates the flow of sensory information starting in the periphery with the sensation, which is fine touch, vibration, pressure, which is further specified as a fine degree of intensity, and proprioception. And each of these sensations acts upon their individual receptors that were previously reviewed, and the receptor sends the signal up the nerve to the dorsal root ganglia, which it should be pointed out that the green lines here represent first-order neurons that take it from the receptor in the periphery up all the way to the brain stem, where it synapses with a second-order neuron, which is illustrated in purple here. And so the first-order neuron synapses in the brain stem with the second-order neuron, which travels up to the thalamus from the brainstem, and synapses with the third-order neuron, which travels from the thalamus up to the cerebral cortex, specifically the post-central gyrus that interprets the sensations such as fine touch, vibration, pressure, and proprioception. Moving on, we're going to discuss in more detail the first-order neuron. It enters the spinal cord through the dorsal root ganglion. It relays sensory information from the dorsal column to the medulla and ascends the spinal cord on the ipsilateral side, meaning the same side that it entered. It synapses with the second-order neuron in the medulla, specifically the cuneate and gracile nuclei. And regarding second-order neurons, it crosses to the contralateral side in the medulla and then ascends towards the thalamus via the medial lemniscus. Second-order neurons are joined by the trigeminal nerve. Recall that the trigeminal nerve provides sensation to the head. The second order also synapses with the third-order neuron in the thalamic relay station, which is in the ventrobasal complex. Regarding the third-order neurons, these fibers pass through the internal capsule and advance towards the somatosensory cortex in the post-central gyrus in the parietal lobe. Next, we're going to talk about sensory pathways involving the anterolateral system, specifically the spinothalamic tract. So, an overview describes the spinothalamic tract as transmitting pain, temperature, crude touch, tickle, itch, and sexual sensation. It consists of smaller myelinated and slower conducting fibers. It transmits sensory information 1/2 to 1/3 as fast as the dorsal column medial lemniscal system. Two-point discrimination is not present. The following picture below shows the pathway using the anterolateral system in the spinothalamic tracts, and similar to before, the sensations are pain, temperature, crude touch, and crude pressure, and these are the types of sensations that are transmitted in the anterolateral tract. And it begins by stimulating the receptor, which sends the signal up to the spinal cord, again through the dorsal root ganglia, and this is again the first order neuron that travels from the receptor to the spinal cord. In the spinal cord, the first order neuron synapses with the second order neuron, and it actually has a more complex pathway where it synapses with one neuron and then can travel in different pathways, and it skips the brainstem. It doesn't synapse in the brainstem anyway, and it travels up and enters the RAS and the thalamus, and then from there it synapses in the third order neuron, which travel up to the cerebral cortex, specifically the postcentral gyrus. Peripheral receptors are free nerve endings and nociceptive receptors, and the first order neuron enters the spinal cord through the dorsal root ganglion. The cell body is in the dorsal root ganglion, and it may ascend or descend 1 to 3 levels on the ipsilateral side via the Lesueur tract before synapsing with the second order neuron. Synapses with the second order neuron in the dorsal horn laminae 1, 4, 5, and 6. Pain neurons synapse in the substantia gelatinosa and lamina 2 and 3. So again, the first order neuron synapses with the second order neuron in the dorsal horn laminae 1, 4, 5, and 6. And pain neurons synapse in the substantia gelatinosa and lamina 2 and 3. Regarding the second order neuron, It crosses to the contralateral side of the spinal cord and ascends towards the brain via two pathways, the anterior spinal thalamic tract and the lateral spinal thalamic tract. Cell bodies reside in the dorsal horn of the spinal cord. Second-order neurons synapse in the reticular activating system, which is the RAS, and the thalamus. Regarding third-order neurons, most tactile signals are relayed to the ventrobasal complex of the thalamus. These fibers pass through the internal capsule and advance towards the somatosensory cortex in the postcentral gyrus and the parietal lobe. Most pain fibers synapse with third-order neurons in the reticular activating system, and from here, there are connections to the thalamus. Moving on, we're going to talk about motor pathways, and these involve the corticospinal tracts. This is the most important motor pathway. This pathway is often referred to as the pyramidal tract. The pyramids are formed by the corticospinal neurons as they run through the medulla. All the other motor pathways outside the corticospinal, meaning pyramidal tract, are known collectively as the extrapyramidal tracts. This is because the fibers do not pass through the pyramids. So the following picture is an overview of the corticospinal tract, and you can see the pathway from the upper motor neuron, which is the lateral corticospinal tract, and limb fibers. And this is illustrated on the left in purple. And it travels from the cerebral cortex in the precentral gyrus down the medulla, where it crosses over to the contralateral side, and then travels down into the spinal cord, where it synapses with lower motor neurons, and this is depicted in green, that travel to the limb muscles and axial muscles. It only travels to the limb muscles. The axial muscles are part of this other pathway, which are illustrated on the right, and it's in a maroon color, and it illustrates upper motor neuron pathways from the ventral corticospinal tracts and axial fibers traveling from the cerebral cortex and the precentral gyrus down the medulla, where it crosses through the medulla and then enters the spinal cord, where it then moves over to the contralateral side and synapses with the green lower motor neuron in the ventral horn, and then travels to axial muscles. So again, there's two pathways here. Both of them are from upper motor neurons, and one involves the lateral cortical spinal tract, illustrated in purple, the one we reviewed first, and then the ventral corticospinal tract is in a maroonish color, which we talked about second. The ventral corticospinal tract crosses over in the spinal cord, and the lateral corticospinal tract crosses over in the medulla. And both of them synapse with lower motor neurons in the ventral horn. Motor neurons exit the precentral gyrus of the frontal lobe and pass through the internal capsule and then travel inferiorly through the pyramids of the medulla. Regarding the lateral corticospinal tract, these fibers innervate the limb crossover to the contralateral side in the medulla. From here, they descend the spinal cord via the lateral corticospinal tract. Regarding the ventral corticospinal tract, the fibers that innervate the axial muscles remain on the ipsilateral side as they descend via the ventral corticospinal tract. Most of these fibers cross over to the contralateral side of the spinal cord when they reach the cervical or upper thoracic area. Next, we're going to discuss upper motor neurons in some detail. These neurons begin in the cerebral cortex and end in the ventral horn of the spinal cord. An injury to the upper motor neuron is as follows. The cell bodies of the upper motor neuron originate in the cerebral cortex. If an injury occurs above the level of decussation in the medulla, then paralysis will be on the opposite side of the body. If an injury occurs below the level of decussation in the medulla, then paralysis will be on the same side of the body. There is a subset of neurons in the corticospinal tract that exert an inhibitory influence on lower motor neurons. This inhibitory action prevents the lower motor neurons from firing too frequently. Since inhibitory impulses from the brain are blocked at the level of injury, there is an overactivity of the lower motor neurons and manifests as hyperreflexia and spastic paralysis. Examples of upper motor neuron disease include cerebral palsy and amyotrophic lateral sclerosis. Regarding Babinski's sign, this test is a method to test the integrity of the corticospinal tract. A normal response to a firm stimulus to the underside of the foot produces a downward motion of all the toes, so normal is down. Damage to the corticospinal tract is when a firm stimulus to the underside of the foot produces an upward extension of the big toe with fanning of the other toes. This is a positive sign and is bad. It indicates damage to the corticospinal tract. Regarding lower motor neurons, the lower motor neurons begin in the ventral horn and end in the neuromuscular junction. Injury to a lower motor neuron means that these peripheral motor nerve fibers are linked to the spinal cord and a muscle. So there are links between the spinal cord and a muscle. The cell bodies of the lower motor neuron originate in the ventral horn. So injury to a lower motor neuron results in paralysis on the same side of the body as the injury, and lower motor neuron injury presents with impaired reflexes and flaccid paralysis. The Babinski sign is absent with a lower motor neuron injury, so you won't get the toe up and fanning with a lower motor neuron injury. The following is a review of acute spinal cord injury and neurogenic shock. Acute spinal cord injury is most likely to result from a motor vehicle accident, fall, assault, or sport injury, and C7 is the most common site of spinal cord injury. Complete spinal cord injury damages the upper motor neurons, which initially leads to flaccid paralysis and loss of sensation below the level of injury. Loss of bowel and bladder function occurs as well, and after the acute phase, spinal reflexes return and may lead to spasticity. In addition to paralysis, there is a concurrent hemodynamic derangement known as neurogenic shock. Hemodynamic instability is greatest with injuries to the cervical or upper thoracic cord. The higher the injury, the greater the degree of hemodynamic instability. Spinal cord injury with neurogenic shock is characterized by sympathectomy below the level of injury. This manifests as a triad of hypotension, bradycardia, and hypothermia. Neurogenic shock can last 1 to 3 weeks. Regarding the pathophysiology of neurogenic shock, impairment of the cardioaccelerator nerves, meaning T1 to T4, results in unopposed cardiac vagal tone, leading to bradycardia and reduced inotropy. Decreased sympathetic nervous system tone, vasodilation, venous pooling, and decreased cardiac output and blood pressure. It also impairs the sympathetic pathways from the hypothalamus to the blood vessel, leading to the inability to vasoconstrict or shiver, and hypothermia. Hypothermia is a result of the inability of the cutaneous vasculature to constrict, causing a redistribution of blood flow towards the periphery and allowing more heat to escape from the body. In the trauma patient, the neurogenic shock may be confused with hypovolemic shock. Neurogenic shock leads to bradycardia, hypotension, hypothermia with pink and warm extremities, and hypovolemic shock leads to tachycardia, hypotension, and cool, clammy extremities. Norepinephrine is a good choice to restore systemic vascular resistance and inotropy. Volume expansion is required as well, but keep in mind that over-resuscitation may lead to myocardial dysfunction and pulmonary edema, particularly after the sympathectomy resolves. An arterial line will help determine the adequacy of both of these endeavors. Although succinylcholine should be avoided 24 hours after the injury due to upregulation of extrajunctional receptors, fasciculations may worsen outcomes with spinal cord injury. For this reason, it's prudent to forego the use of succinylcholine altogether. In a testing situation, if you're given the option, you should always select a non-depolarizer over succinylcholine. If you must use succinylcholine, pay attention to the timing of administration relative to the timing of spinal cord injury. The major cause of morbidity and mortality in patients with cervical and upper thoracic lesions are ineffective alveolar ventilation and inability to clear pulmonary secretions. Moving on, now we're going to talk about chronic spinal cord injury, and this is relevant for autonomic hyperreflexia. After the spinal shock phase ends in 1 to 3 weeks, the body begins to mend itself in a pathologic and disorganized way. There is a return of spinal sympathetic reflexes below the level of injury, however, without inhibitory influences that would normally come from above the level of the injury. The sympathetic reflex below the level of injury exists in an overactive state, and this places the patient at risk for autonomic hyperreflexia, otherwise known as the mass reflex. While up to 85% of patients with the injury above T6 will develop autonomic hyperreflexia, it is unlikely to occur in patients with an injury below T10. The higher the level of injury, the more intense the response. Common events that autonomic hyperreflexia include are stimulation of the hollow organs, meaning bowel, bladder, or uterus, bladder catheterization, Surgery, especially cystoscopy or colonoscopy, bowel movement, cutaneous stimulation, and childbirth. So those are common events that cause autonomic hyperreflexia. Moving on, we're going to talk about the pathophysiology. The classic presentation of autonomic hyperreflexia is both hypertension and bradycardia. Stimulation below the level of the spinal cord injury triggers a sympathetic reflex arc that creates a profound degree of vasoconstriction below the level of the injury. This activates the baroreceptor reflex in the carotid sinus, which slows the heart, and the body attempts to reduce the afterload with vasodilation above the level of the injury. Other signs and symptoms include reflex vasodilation above the level of the spinal cord injury, leading to nasal stuffiness, hypertension, which manifests as a headache and blurred vision, and malignant hypertension, leading to stroke, seizures, left ventricular failure, dysrhythmias, pulmonary edema, and or myocardial infarction. And the following flow chart reiterates what we've already discussed. So you have stimulation of below the spinal cord injury, leading to activation of sympathetic nerves, which leads to vasoconstriction below the injury, which leads to hypertension manifested by headache, blurred vision, left ventricular failure, pulmonary edema, dysrhythmias, strokes, and seizures. And then the hypertension is attempted to be controlled by the baroreceptor reflex in the carotid sinus, leading to bradycardia and vasodilation. The sympathetic nerves below the level of injury do not receive inhibitory signals from the brain and do not vasodilate when the baroreceptor reflex is activated. Regarding anesthetic management, even though the patient does not have sensation below the level of the spinal cord injury, stimulation to the affected areas can elicit autonomic hyperreflexia, so prevention is paramount. General or spinal anesthesia are the best options. An epidural may be used for the laboring mother. However, when compared to a spinal anesthetic, an epidural does not inhibit the sacral nerve roots to the same degree. Hypertension is best treated by removing the stimulus, deepening the anesthetic, or using a rapid-acting vasodilator such as sodium nitroprusside. Bradycardia can be treated with atropine and glycopyrrolate, and administration of a positive chronotrope with vasoconstrictive properties will worsen hypertension. Adding lidocaine jelly to the cystoscope or Foley catheter does not prevent autonomic hyperreflexia. Succinylcholine is contraindicated in the patient with chronic spinal cord injury, and autonomic hyperreflexia may present in the post-op period as the effects of anesthesia wear off, so close post-op monitoring is warranted. The following is a discussion on amyotrophic lateral sclerosis. ALS causes progressive degeneration of motor neurons in the corticospinal tract. Astrocytic gliosis replaces the affected motor neurons, and both the upper as well as the lower motor neurons are affected. The etiology is unknown. Signs and symptoms include upper neuron involvement presenting as spasticity, hyperreflexia, and loss of coordination. Lower motor neuron involvement presenting as muscle weakness, fasciculations, and atrophy. And it often begins in the hands, and over time weakness spreads to the rest of the body, affecting the tongue, pharynx, larynx, and chest. The ocular muscles are not affected. Autonomic dysfunction is evidenced by orthostatic hypotension and resting tachycardia. Sensation remains intact. Riluzole is an NMDA receptor antagonist, and it is the only drug that reduces mortality. Respiratory failure is the most common cause of death. Regarding anesthetic management, there is no evidence to support a clear benefit of any particular anesthetic technique. Succinylcholine can cause lethal hyperkalemia, and lower motor neuron dysfunction is associated with the proliferation of post-junctional nicotinic receptors. There is an increased sensitivity to non-depolarizing neuromuscular blockers, and bulbar muscle dysfunction increases the risk of pulmonary aspiration. Chest weakness reduces vital capacity and maximal minute ventilation, and you should consider postoperative mechanical ventilation.